So today is a mock test, and as I told you in the mock test, we recently introduced a new module, right? So on new mock test, we introduced new module on the website. I had given little demo before the class. Use it and track your record of your progress, right? So how, right? Your progress can be now clear cut, computer, right? Monitored on your computer and your screen, right? So how much you are improving, you can see all the track record of your all earlier this mock test, and even I can monitor. So even I can assess your mock test. So you are giving mock test, but I can see that mock test, what you have done, what's your score, when you had given, where is your mistake, right? So that also I can monitor from the admin panel as well. So let's jump to the main things. Everybody get ready with the pen and paper. I'll give you 15-30 seconds. I prefer, please make a mic mute. If you want to interact with me, you can unmute anytime. We'll go properly, thoroughly, not in hurry at all. We need to do at least 50 MCQ, 50, though I discussed 15, 16, but in 16 I covered almost 50 MCQ. So just concentrate on things properly and try to understand. So first questions in front of your screen. A 50 years old man with diabetes and hypertension complained of central chest pain while walking this morning. The pain lasted 10 minutes, was relieved by the rest and has not occurred before. Examination and resting EKG or ECGs are normal. Which of the following is the most appropriate next step investigation? Chest X-ray, echo, uh, exercise, echo test, repeat echocardiogram in 1 week, and you will going to go for thallium scan. So these are the what few other questions. What is the diagnosis? What is the treatment? So you think of the answer. Meanwhile, I'll tell to a new guy or new doctors who are joining the first time. Whenever you start your MCQ, doctor, always remember this triad. It is extremely important triad for MCQs, right? When you are solving the MCQ, you must know the diagnosis of the MCQ. So there must be some diagnosis. So I need a diagnosis, what this patient is suffering from, right? Right? So to do this diagnosis, how you investigate this patient, and once you diagnosed and investigate this patient, how you gonna treat this patient. So you must know in each MCQ three parts: what's the diagnosis, what's the investigation, and what's the treatment. So say for example, in a day you are solving 50 MCQ, means you are almost trying to solve 150 MCQ by answering all these three things. So don't do the MCQ monotonously or robotically, that okay, what is the what they ask investigation, so just concentrate on investigation. You concentrate on along with the, so if they ask this, you need to answer this too. If they ask diagnosis, you need to answer this too. If they ask treatment, you need to answer this too. So always try to cultivate the practice of answering three questions in each MCQ. That is the diagnosis, investigation, and treatment. So now let's review the answer. There are a lot of people who had given the answer. So let's see who has given the answer, right? So yes, Dr. Iram. Now we'll discuss these questions, right? So I'll discuss this question with you,
Sure,
doctor.
sir.
Yes. So now first of all, tell me, doctor, what is the diagnosis of this patients or tentative diagnosis, right? Don't worry about right or wrong. If you
Sir,
interact, you will definitely never going to
yes,
forget
sir.
these things. Yes. Go ahead. Diagnosis.
Unstable angina or maybe NSTEMI.
Okay. So what's the again more specific things? What's the first preference? NSTEMI or unstable? You read it once
NSTEMI.
again. We are not in hurry.
Unstable angina.
Not NSTEMI. Unstable angina.
Unstable angina.
Okay, let me go one by one. Let me finish with Iram. I will get back to you. Unstable angina, doctor. Okay, this question is of Dr. Iram. Yes, Dr. Iram. Now tell me three difference: stable angina, unstable angina, non-STEMI, and STEMI. What is the difference between these all four? Let's come to the new page. Unstable angina, stable angina, non-STEMI, and STEMI. How you differentiate? First, tell me the stable angina. First, tell me the stable angina. What's your impression in your mind for the stable angina? If I tell you, doctor, I have one
Hmm.
patient of stable angina, what impression it creates in your mind about stable angina in terms of three things? How they present means history. What's the history of stable angina, right? What's the ECG of stable angina? What is the enzyme in stable angina? right? And how you treat the stable angina. These four things are we need to know for all each and every. So if you understand these four things, whatever the answer they ask you in exam about acute coronary syndrome, you are the most expert one in the examination hall. We need to know four things for all four entity. Yeah. Would you like to attempt or not?
Yes, sir. I will.
Yeah.
I
So
want to.
yeah. So what's the history in stable angina? How basically stable angina present?
Stable angina patient present with the chest pain only on the like
Chest pain,
activity or stress.
activity or stress. Fair enough. Okay. And how does it relieve? So when they do the activity, they feel chest pain or heaviness, or on the stress they feel chest pain. Is it relieved by something?
ECG will be completely normal and
ECG
enzymes
could
will
be
be completely normal and
wonder.
it relieved by generally by rest only.
Okay, excellent. 10 out of 10. Absolutely agreed and convinced. Great. This is about stable angina. What about the unstable angina? All four things are about unstable angina.
In unstable angina, patient will have pain with stress and activity, but the pain will last longer.
Okay, pain will last longer. Okay, fine. So what's the ECG and enzyme in the unstable angina?
Both of them will be completely normal.
Wonderful. So this is normal in unstable angina. Here, little I write down. So what is the pain? Is a chest pain, probably last longer, right? Probably little severe, right? But if you do the ECG and enzyme, it's normal. How it gets relieved, or what's the treatment of unstable angina? How you treat?
Rest only.
Rest only. So do you feel that unstable angina will relieve with the rest only, or you need to add something on top of this rest?
Mm, I'm not
Otherwise,
sure.
it looks, yeah. Anyone unstable angina treatment?
You need to give low molecular
Aspirin.
heparin.
Heparin,
Sir, nitroglycerin.
nitroglycerin. Lot of answer. Nitroglycerin, heparin. Why you want to give heparin in unstable angina? How it's going to help to the unstable angina?
It's going to lyse the means the thrombosis. It prevents the further thrombosis,
Mm-hmm.
aggregation of platelets.
Mm-hmm. Okay. So
Nitroglycerin can only just dilate the arteries.
okay, fine. So
This will arrest the progress of the atherosclerosis changes.
okay. So your homework today is to read just only one topic, that is unstable angina,
Okay.
right? And we'll discuss in the group again. Fair enough. Right? Okay, fine. So this is like more severe pain. It is usually not relieved after ERM by rest only. You need to add something, right? Unstable angina. Pain is not stable, unstable angina. So angina is there. So it's not just relieved by the rest. Probably exercise, stress may precipitate the unstable angina. But if you do the ECG enzymes, they are normal. Why? Because the blood supply is there, right? Cardiac muscles are not died or dying, right? So supply is there, but there is a coronary vasospasm, and because of that you may have unstable angina, right? So if you do the rest, if you do some vasodilator, it will improve the blood flow and patient gets better, right? Non-STEMI. So now again, Iram, tell me what four things in non-STEMI in terms of
So, sir,
history. Yeah.
in NSTEMI, patient will present with typical chest pain even at rest, that crushing
Okay.
or sweating or radiating to shoulder
Fair
and
enough.
neck, everything.
Fair enough.
ECG will show no ST elevation, which is typical for the MI. It might show ST depression.
Okay. So ST depression would be there. This is most important thing. ST depression would be there. Another is it could be normal in early stage, or there may be a T inversion. This is things for unstable, sorry, non-STEMI, right? Non-STEMI means non-ST elevation. So there is absolutely no ST elevation. So if there is no ST elevation, means it could be ST depression, or ST could be normal, or there is just the T wave inversion. This is what the ECG finding you can find. Okay, so there is a chest pain which can be at rest as well, maybe more severe, cannot be relieved by nitroglycerin, right? And you, if you do the ECG, you see the ST depression, you can see the normal, or you can do the T inversion, you can see, right? What's the enzyme level? What's the enzyme? It is
Enzyme
normal
will
or
be
elevated?
elevated, sir.
Enzyme will be elevated. Which enzyme would be first elevated, or which is the most
Uh,
sensitive and specific enzymes, right? what is the
Tropi.
most sensitive and specific? Sensitive and specific. If I tell you do only one blood test to confirm whether it is a MI or not, right? This
Sir,
is also
tropi.
this is MI, this is also MI. This is ST elevation, this is non-ST elevation, but both are MI. So when there is a MI word, MI means myocardial infarction. Myocardial infarctions means there is a hampering of the blood flow to the muscle of the heart. That is called MI, myocardial infarction. Ischemia is different, infarction is different. Ischemia just reduction of the blood flow. Infarction means because of the blockage there is a dying of the cardiac heart muscle or myocardium, right? And that is called infarction. So ischemia is less severe, infarction is a more severe, right? So this is a infarction. So troponin I, troponin T or troponin I will gets elevated in the blood, right? When it will start elevating, Dr. Idam? So 1 o'clock patient comes to you with a chest pain and he is saying, I just started, just 1 minute back, I get the chest pain and it is increasing now. ECG is showing ST depression. You send the trop I when you supposed to see that there is an elevation of the trop I in the blood. Immediately it's not elevated. Immediately if you send the trop I is normal. So 4 to 6 hour time it will get elevated. So 1 o'clock patient has chest pain. You expect earliest 5 o'clock, right? 5 o'clock. You probably think that okay, this will high. So immediately if you send the blood test, even the ST is depression, right? Even though the tropi is normal, so it start elevated at the 4 to 6 hours. It gets peak at the 12 hour, and it will go back, right? Right? It will
Yes.
become normal in what time? These all are
24 hours.
MCQ. These all are MCQs. How many hours? Anyone? When this gets normal? These all three questions. Which is the most sensitive and specific matter, troponin T or I? At what time it will get peak? Right, start, I mean, raising the troponin I, when you can earliest detect after how many hours of acute MI you can enzyme gets elevated 4 to 6 hours. At what time the enzymes get elevated 12 hours. And this is the period why if we suspect some patient as a myocardial infarction, we keep 12 hours patient in the monitoring or in the daycare, right? Even though ECG is normal, even though the enzymes are normal, and if you think clinically this is hypertensive, diabetic, smoker, family history, elderly, obese patient, earlier ischemic event, and still you do the ECG enzyme and both are normal, right? But your clinical suspicious is so high that this is until proved otherwise MI classical by history, even though you keep these patients under observation 12 hours, and every 1 to 2 hours you ask for the ECG as well as enzyme. So within 12 hours, ECG may have changes which is normal earlier, and enzyme may have changes at the end of 12 hours, right? So if it is MI, then 100% it is picked up. You will not miss this, otherwise you will miss it, right? So don't miss it. You try to do it properly, right? So what I used to do, what the guideline says, that if you suspect any patient as acute MI, right, and if ECG enzymes are normal, put them under observation for 12 hours. If everything is normal at the end of 12 hours, that means there are least chance that this patient is suffering from MI. Is that clear, Iram?
Yes, sir.
Wonderful. And now, last but not the least, so what is the STEMI? How you differentiate between STEMI and non-STEMI? Let's come to that point. The most important and most critical part. So how you differentiate between STEMI and non-STEMI? How clinically different by history, by enzymes, by ECGs, and by treatment, how they differ from each other? Tell me.
Yes, sir. So ST elevated MI patient will present with chest pain, crushing type, and sweating, vomiting, radiating to shoulder and neck, even at rest. And ECG will show typical ST elevation regarding to whatever vessel involved.
So history, if I can say chest pain, it's present in both. So honestly speaking, hopefully you have also good experience, but I'm practicing almost for 25 years now. I was an emergency physician before I jumped into the hematology. So chest pain pattern from outside, even best of the best cardiologists cannot differentiate by the history. This chest pain is STEMI, this chest pain is non-STEMI. Is that clear? Yes or no? Right? So
Exactly.
chest pain is the just symptoms for you to think of MI, right? But STEMI or non-STEMI, you cannot differentiate by the history. This is what I mean to say, right? So history will give you the idea, okay, fine, it could be MI. But you cannot say by, oh, this is the pain, it is non-STEMI. This is the pain, it is STEMI. Never. No cardiologist in this world can differentiate STEMI to non-STEMI. So STEMI and non-STEMI is what the diagnosis. It's a diagnosis by ECG. This is P, this is Q, this is R, this is S, and this is T wave. This is normal basically, right? Here now, if you see the non-STEMI P, right? Q, R, S, T depression, right? So here ST depression, and here how the ECG P, Q, R, S, T, this is ST elevation. So this is ST elevation is STEMI, ST depression or normal. This is ST depression is non-STEMI. So this is 100% diagnosis of ECG, not 99%. So without ECG, no cardiologist in this world can differentiate this is STEMI or non-STEMI, right? So this is history will give the clue. And third thing, diabetic mellitus patient probably may not have any chest pain. Keep in mind, it is called a silent MI. Have you heard, Dr. Iram, about silent MI? Silent
Yes,
MI.
sir.
So silent MI is MI in which you don't get any pain. Why? Because in diabetes there is a autonomic
Peripheral
neuropathy,
neuropathy.
peripheral neuropathy, autonomic nervous system involved. There is a neuropathy, and because neuropathy, pain sensations are gone. So this is a the most worst patient. Diabetic patient with MI is worst patient. Why? Because you miss, na? If 2 o'clock in the night the patient comes to you, right, and you ask, do you feel chest pain? No chest pain. And when somebody say you no chest pain, will absolutely you forget about doing the ECG. What's the impression in your mind and everybody's mind? Chest pain, do ECG. No chest pain, don't do ECG. But in diabetic patients, so if you feel on a clinical ground, if the patient is diabetic and if have anything like chest pain, breathlessness, heaviness in the chest, right, burning in the chest, tightness in the chest, squeezing in the chest, and one another in India we called as a gabraman. I don't know whether you heard this word or not. Gabraman, feeling uneasiness. In emergency, I make a rule in my emergency: whenever any patient more than 40 years of age comes with in emergency, do the ECG, irrespective whether there is chest pain or no chest pain. If it is normal, we are happy, right? Medically as well as legally, because you don't want to die someone, right? And ECGs, I think it's underutilized test, underutilized. We are not doing lots of ECG, underutilized test. So you try to use maximum your ECG machine, try to do maximum ECG. Believe me, out of 100 you will pick up two good patients which usually missed, and they end up with the mortality. So we don't want to do any mortality. So this is absolutely a ECG finding STEMI and non-STEMI. Enzymes, it gets elevated in both. Am I right, Iram? Right?
Yes, sir.
Troponin T, I, CKMB, whatever. And the most critical part is the treatment. Now tell me the important three treatment of this patient, Dr. Iram. What is the first treatment when this patient non-STEMI? So now I'll give you the scenario: 59 years of male diabetic patients presented with chest pain, right? You did a ECG showing ST depression. You send for the enzymes, troponin T and troponin I both are high, right? Now the diagnosis is acute non-STEMI, right? Acute MI,
Yes.
which is non-STEMI. Now, how you'll gonna treat this patient?
So sublingual nitroglycerin, oxygen, analgesia, and aspirin.
Okay, so
Una.
short form is MONA. This is what we called as a pre-hospital care, pre-hospital care as well, right? That can be done by anyone. Cardiologist is not required at this point of time. M stands for morphine. Morphine reduces the pain. Normal NSAID will not reduce the pain because this is a severe pain, right? Cardiac muscles are dying because of lack of blood supply. So it is a, like, if you know the pain score 1 to 10, this pain score is 8, 9, 10, right? It's a severe kind of pain. So you need some opioid analgesic. So morphine. Oxygen is given to all patients, even though oxygen saturation is normal. This is a question in exam, but still you can supplement, right? Nitroglycerin is the drug vasodilator which open up little coronaries, try to improve the blood flow and reduce the pain. So this is again for the pain, right? Nitroglycerin also release the pain. How you it reduce? It dilate. It's a vasodilator drug. It dilates artery, dilates vessel. So your pharmacology should be also little better, right? So nitroglycerin or NTG, nitroglycerin, is a vasodilator drug which vasodilator arterial or venous both it dilates the, right? So if this is coronary, it makes the coronary big, so blood flow is better, right? So it just reduces the pain. It has nothing to do with the clotting, it has nothing to do with the atherosclerosis, it has nothing to do with the calcification in the vessel. Just dilate the vessel, that's it. And aspirin is the drug, the number one drug which saves the life, right? Because aspirin is an antiplatelet drug. It try to reduce the clumping of the things. It try to prevent the further clot formation, right? So it is prevention. Keep in your mind, it will not dissolve the clot 100%. It will not dissolve the clot. It helps to prevent the clot for further formation. So if the artery is 70% blocked, so it helps to hold at 70%, but it will not do 60%, or it will not open up the vessel. It try to prevent the further aggregation of the platelet at the site of the clot or thrombus, right? So aspirin reduces the mortality in unstable angina. As per the master the board, 50% reduction in the death, immediate death, and in acute myocardial infarction it is 25% reduction in the death. If you give the aspirin on time, it is the life-saving drug, life-saving. So if Iram, doctor, I give you the options, which drug you want to give first? If you have four drugs all available in your emergency room, to which you give the first priority?
Sir, I'll do aspirin loading 325 mg.
Great. So first you give the aspirin and then you give morphine or nitrate, oxygen, blah, blah, because this is earlier you give, earlier the chances that you further prevent the clot formation, prevention. And the patient who dies immediately is because of the, it was complete blockage of the vessel, acute MI, sudden cardiac arrest, death, arrhythmia, ventricular fibrillation, death. What we see in our practice, right, is this event, right? So when patient comes MI, right, after 15 minutes, if you don't do, go into the ventricular fibrillation, they die, that's it. Within 10 minutes they die. So this is the one. So once you given the Mona, what was the number, right, second choice of the treatment? This all are all questions in exam. What I'm trying to discuss for last 15 minutes, all questions in exam, believe me, or everything will come. So try to understand the logic, and end of the session, if you don't understand, ask me. So what, once you given Mona properly, right? What is the next option? What is the next best option? Your hospital is one of the best hospital in the world. You have all resources. Whatever you want to do, you can do it. So now, what's the best option?
Sir, percutaneous intervention, angioplasty.
Okay, so PCI basically percutaneous coronary intervention. This is the word as per the book, right? PCI, right?
Yes, sir.
Percutaneous coronary intervention. Okay, and say for example, it is not available in your hospital. Your hospital is very small hospital sitting in remote area in Dubai, and now you have chest pain. You are a small clinic. You had given Mona. You transfer the patient because you don't have anything, or you have little bit facility. If the PCI is not available in your premises, what will you give next? This is exam question. This is exam question that blah 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 male presented with acute MI, Mona is loaded. Now what is the best treatment option? Best treatment option is PCI, but PCI is not available in your hospital. What do you do the next? That's the question. MCQ. Thrombolytic.
Thrombolysis.
Right, thrombolysis. Right. So so sorry. Let me little do a fine adjustment. I thought I'm discussing STEMI. So for non-STEMI, first you give the Mona. So let me erase the things for better clarity. Right. So you so far understand well, right? Right.
Yes, sir.
Yeah. So treatment is important because this is the things which will save the life. So it's a life saving. So we must know it. So treatment here, whether it is a non-STEMI or STEMI, both are Mona because they both are MI. Morphine, oxygen, nitrate, aspirin. Now non-STEMI, what's the pathology? Non-STEMI is probably still there is a, this is a thrombus, say for example, this is thrombus, but still it is still little open, so blood can pass from one place to another place. From this is a entry and this is exit, so still there is a some blood flow. It is not 100% block, it is not 100% block, while STEMI 100% block, 100. So this is more severe, right? So the question is, what is the most severe condition in acute coronary syndrome? Non-STEMI, STEMI, angina, unstable or stable. Most dangerous is the STEMI. 100% block. So you need to open it as soon as possible, as ASAP, as soon as possible. You need to open up. Otherwise, these guys are under very much bad condition. They will die. Believe me, they will die in 5 minutes. If you don't do, if you waste the time, they will die. So Mona is the first step. Mona is the first step for both the things. Second thing for the non-STEMI, non-STEMI is a not 100%. So second step here in non-STEMI is a thrombolytic. And third thing, once you thrombolize the things, you don't want the second time patient after 6 months again come with the STEMI. Then you do the PCI, try to find out where is the blockage, how much is the blockage, and treat with the stent accordingly, right? And here the little fine adjustment, STEMI means 100% block. You give Mona, try to open up as soon as possible, and fastest things in the world which can open up the coronary is PCI. Fastest things in the world which can open up the coronary immediately within 5 minutes is the PCI. So PCI, and if the PCI is not available, then you can do the thrombolytic, right? If not available, so if this is not available, do thrombolytic, and after thrombolytic, you refer the patient to higher center for PCI. Why? Because you did a temporary opening of the coronary by lysing the blood clot, right? But again, if you don't do proper treatment, again after 6 months, this patient come with a second MI, right? Again, it would be a massive MI, right? Probably it was earlier in one vessel is blocked, right? Now it is a two vessel block. And if you don't take care, all three vessel, that is called triple vessel disease, right? So here the little fine adjustment, non-STEM is not that critical. So Mona first, thrombolytic, after thrombolytic give PCI, do PCI, and treat if there is a blockage. If otherwise, conservative treatment. If the blockage is not much, maybe less than 50%, sometimes cardiologists say, okay, you do the conservative treatment. And here Mona, do the PCI. It is the best. This is the commonly frequent asked question in DHR, the MOH, Oman, everywhere, right? So PCI, but if PCI is not available, then you go for the thrombolytics and do the maintenance treatment like lifelong clopidogrel.
अनम्यूट करने से मैं बात कर सकता हूँ ना?
So this is how it works, right? So Dr. Iram, I think you got my concept, right? What I'm basically trying to explain you or everybody, right? By
Yes,
this
sir. I
chart.
have a doubt, sir.
Yes, please. Now you ask me all doubts. So far it's clear, right? So far it's clear.
Right, sir. It's
Wonderful.
completely clear.
Wonderful. Tell me now, what's the doubt?
So there are two things, thrombolysis and this PCI.
Yes.
There is a quote that when patient present within 90 minutes of MI, you should take patient for the PCI. And so I want to know what is the time frame of thrombolysis? Like patient present within such particular duration, then only we can do thrombolysis.
There is a word, technical one. Needle, door to needle, and door to balloon. Have you heard of this word?
Sir.
Door to needle and door to balloon is a book word. Door to needle, when patient comes to you in emergency room, right? The maximum time, right? Maximum time door to needle is a 30 minutes, means thrombolytic. If you want to do the thrombolysis, preferably you do it in within 30 minutes because it has a maximum advantage. Larger the time, 60 minutes, 90 minutes, 120 minutes, heart muscle will die. Why? Because they are not getting the blood supply. Are you getting me? Right? So
Yes, sir.
earlier you do any intervention in terms of drug or in terms of catheter, it will give the maximum advantage. So door to needle, needle means you are giving some kind of injection via needle, and injection is a thrombolytic. So if you can, your hospital can able to manage within 30 minutes, it's a great time. So this is called door to needle time is what? 30, 60, 90 or 120 minutes. Answer is 30 minutes. Door to balloon. Door to balloon means balloon is angioplasty. Balloon angioplasty. The word is balloon angioplasty. So if you can able to do it in within 90 minutes of acute MI, so this is from acute MI to 90 minutes. This is acute MI diagnosis to 30 minutes. So this is called door to needle and this is door to balloon. But STEMI, there is no controversy across the globe. First thing is a Mona, immediately open for PCI. If PCI is not available, then do thrombolytic and go for PCI. So I have many patients, right, who have middle of the night chest pain, right, and cardiac hospital is probably 1 hour far, right. I need to save the life. Patient is not stable, so I immediately give this thrombolytic, and after once the patient gets stabilized, right, patient clots is open, ST elevation is getting down at the end of 24 hours. Then after 2-3 days, 4 days, I will ship the patient to a coronary unit, right, or cardiac care unit or catheter unit, right, and they will do the angiography, and if required they will do the angioplasty on the same sitting. So if the two vessels are blocked 70%, say for example left coronary left anterior descending and left circumflex example, so they put both the stent in both the things where more than 60-70% blocked, patient is symptomatic, there was clear cut MI, and they will do the stenting. And if all the three vessels block, right, all the three vessels block, then you need to do cabbage, that is CABG. So triple vessel disease, usually the treatment is a cabbage. So this is exam
Yes, sir.
questions, right? If you have single vessel disease, you can do stent. If you have two vessel disease, stent. But if you have two vessel disease plus diabetes mellitus, better you go for CABG. If you have three vessel disease, there is a CABG, and there is a left main coronary artery, left main, it is CABG. There is no stent in left main. So these are the few indication of doing the stent, doing the cabbage. So it is very clear cut given in the book anyway. So I just try to briefly highlighted you. So that's it. This is what the thing is. But STEMI means PCI. If PCI is not available, then you do the within 30 minutes the thrombolytic. Is that clear, Dr. Idam?
Yes, sir.
Right? So if you have options of PCI, 100% you go for PCI. No doubt, no discussion. But if you have no facility, that does not mean you can't treat the patient. So you give the thrombolytic. Another homework for you guys, everybody, what are the absolute contraindication of thrombolytic? Very high yield question in exam. Anyone? Anyone wants to attempt rather than
Coagulation disorder.
absolute? I'm talking about absolute, where you cannot give at all. Absolute. I don't want relative contraindication. Absolute contraindications of thrombolytic. Very frequently asked question in exam. Yes, number one.
Sir, ITP.
Okay, so let me little ask you in detail. ITP means what, and at what platelet count you cannot give the thrombolytic? Because ITP, if you have 120,000 platelet, it can be ITP. It can have 50,000 platelet ITP, less than 10,000 platelet ITP. So is there any platelet cut mark where you cannot do the thrombolytic? Sorry to ask you, but this is a logic question. Na? ITP could be anything. If I tell you I have a hypertension, so I have mild hypertension, I have moderate hypertension, I have hypertensive emergency, all are hypertension. So this all three category can be ITP. So what is the number? I want the number of the platelet below which you cannot give the thrombolytic. So if you don't know, go and read it. It is a very important question in exam and it's high yield question. Okay, anyone wants to answer this ITP wala question? Anyone? Any guess? Fair enough. So if you don't know, don't get stressed. Go open up the book today, right? And read the absolute contraindication of thrombolytic, because whenever you give thrombolytic, first thing should comes in your mind, what are the contraindication? Because if the platelet are 10,000 and if you are giving the thrombolytic and patient has a coronary will open up, but he will after 4 hours he will come up with a severe headache and massive intracranial hemorrhage. His brain is full of blood. This is massive hemorrhage, right? So patient anyway die because of intracranial hemorrhage. So you need to balance, na? You need to balance. You need to give, right? Risk and benefit you have to decide. So that does not mean no acute MI thrombolytic de do ho gaya. Doesn't, you need to rule out the things. If patient is 90, right? If patient has a recent intracranial hemorrhage just before 1 month, right? Before 1 month, patient has intracranial hemorrhage, massive surgery was done for intracranial hemorrhage, and within 1 month he present with MI. Are you going to give the thrombolytic to this patient who has massive hemorrhage in the brain? So don't worry, go and read it. Just to save the time, I'll just fasten the things. Otherwise, we could not even complete 15 questions. Is that clear to everyone? So this is all high yield I'm just discussing. I'm not discussing here and there. Absolutely high yield related pertaining in context with the exam I'll just discussing. Iram, is that clear? Any questions in the house? Any questions in the house? Any question?
Clear, sir.
I think you should not have any questions now, but this is what the thing is. If you can see this chart, comparative efficacy of cardiac biomarkers, right? So if you see troponin, troponin is 100% sensitive. So most sensitive amongst CKMB right? Total CK, troponin, highest sensitivity. And if you can see 84, 93, 96. So specificity is high. So 900% sensitivity, 96, 97 specificity. So first number one test is a troponin I. So if you want to do any test in cardiac biomarker, ECG enzymes, you do the troponin. As I told you, troponin gets elevated in 4 to 6 hours, and somebody answer me 12 hours. Somebody answer me within 1 day it will get normalized. So absolutely wrong answer. It will remain elevated in plasma for 1 to 2 weeks, not 1 day, not 24 hours. What will remain in 24 hours is the CKMB, not the troponin I. So this is how I remember. CKMB will remain in blood or plasma is 1 to 2 days, and this is remain in blood and plasma for 1 to 2 weeks. That's it. So just difference of uh, days and weeks. So it's easy to remember. You probably 10, 14 and all you will forget. So 1 to 2 days CKMB, creatinine kinase, muscle and brain. This is how the full form. This is troponin I, protein in the muscle of the heart. That is troponin I. Troponin T is also there, myoglobulin is also there, but myoglobulin is not sensitive and specific. Why? Because if you have skeletal muscle injury, you have a lower limb injury, you have muscle injury, you have myositis, you have some injury to the muscle, myoglobulin will increase. And myoglobulin is in the all muscle of the body, while troponin T and I is only and only in heart muscle. That is why it is a sensitive and specific. That's it. Dr. Iram, is that clear? Is that clear to audience?
Yes, sir.
Light
Yes.
ready.
Great, wonderful. I muted everyone because there are a lot of people are background. So what my thing is, those who have wrong answer in this, right? So again, what's the again? Let gets back to the answer. Anyway, we discussed a lot of things, but did not discuss the answer. So what's the answer, Doctor? Iram,
Sir, exercise ECG.
why you want to do? What is the diagnosis here?
So my diagnosis is unstable angina.
Were great. So unstable angina, obviously, if you have so now if you don't know the answer, this is one of the way or technique by which you can reach to the answer. So in unstable angina, you have nothing to do with the X-ray. So X-ray will not going to help you in unstable angina. So this is gone. Echo, what the echo? It's a heart sonography. So it will give you idea about the ejection fraction. It will give you about the pulmonary artery hypertension, and it will give you the anatomical idea about the valve. So unstable angina is a coronary artery disease. So echo will not give much idea about the coronary artery disease. This will not give you idea about the things, right? Repeat echo in 1 week will not going to help because echo will remain the normal. Now it ECG normal, this normal, patient is fine at rest, patient, right? It never occurred before, right? But the see the risk factor diabetes and hypertension. So you always be a vigilant, and also a central chest pain on walking this morning. So something wrong with the coronary artery. So first you do the exercise tolerance test or stress test. If the stress test is positive, it could be positive or it could be negative. This is the result. If stress test is positive, the you need to do coronary angiography. If you do the coronary angiography, if one or two vessel block, you do the stent. If all three vessel block, it is CABG. This is I'm guiding you the management as well. And if the stress test is normal, nothing to worry. It doesn't look like cardiac. Because when you give the stress to the heart, coronary will always compromise. And when you jump, when you run, you go to the rock, you go to the pilgrimage, and you can climb up the thousands of steps and you have no chest pain, indirectly your stress test is normal, right? So that's the thing. So a stress test is when you do the exercise and same time the ECG is monitored on the machine, and if you find the ECG changes, it is called stress test positive, right? And stress test is positive means coronary is blocked. And how much is blocked, where to block, how much is blocked, and how many block? Only answer is coronary artery angiogram, coronary angiogram, and depends on one vessel, two vessel, or three vessel block. You go for the treatment if stress test is normal. Now tell me, if the stress test patient cannot perform the stress test, Dr. Iram. If
Yes, sir.
patient cannot perform, this patient is 50, but severe osteoarthritis, patient is a severe breathlessness, is a known case of COPD, right? Patient is paralytic patient is a bedridden patient has a hemiplegia, he cannot run on the bed. What will you do? In that case, you do the thallium scan. Is that clear?
Yes, sir.
Thallium
Yes,
scan
sir.
means you are injecting some dye intravenously, and that will constrict the heart muscle, and it acts on the coronary artery, and it will be reflected on ECG, and you get to know whether the thallium stress test, even you can call it as a thallium stress test, right? So thallium is the name of the drug. It's a radionucleotide drug, radioisotope, which you can inject and take a picture and see how much is the difference in the ECG. So normally you run on the belt, right? This is called physical stress test, or you are running on the belt, right? But some patients, because of bad osteoarthritis, hemiplegia, unconscious patient, right? Or psychiatric patients disorder, right? Which they cannot run on the track, that can be done from the drug that is called as a thallium scan. So you go and read it, thallium scan, right? So this is also all exam questions, right? They can ask you in different way. I try to club up all under one roof. That's it. So if your answer is wrong, just try to monitor why it is wrong and where you did the mistake. So your score is 0 if it is wrong. And if you get end of the day less than 50% score, it's not good score. It's not good time to go for exam. Prepare well and again go for exam. Second question, 32-year-old sportsman who recently attended a wild game feed banquet consumed summer sausage made from the bear meat. He complains of abdominal discomfort, diarrhea, and muscle tenderness. The most likely diagnosis is trichinosis, salmonellosis, giardiasis, escheriasis, lumbricoids, and sigilosis. Can anyone tell all of the above can be caused by which organism? That's the second question. So again, think of the triad. If you think of triad, you never go wrong in any MCQ. Only one way in doing mastering the any MCQ is what is the diagnosis, what is the investigation, what is the treatment. So this is all I called as a triad. Yes. You have 10-15 seconds, think over it and give the answer. Yes, Dr. Sultan, would you like to attempt this question? I would be happy.
Because if be a shigellosis is bloody stool, and trichinosis can be show stretch, too much stretch in the anal area, and giardiasis contact with but clean, not clean water. Escheriasis contact with garden cell contact, and so I think salmonellosis.
Fair enough. Let's see what's other. Dr. Pooja, are you there in the class? Dr. Pooja, I think you are there.
Yes.
Would you like to attempt, doctor? What could be the thing? This is what the questions comes in exam. This is how. So don't worry. This is the practice things. So I want to give you the real idea how you supposed to crack the MCQ, not just by reading or mugging up the things. So do you have any idea? I mean, how you gonna answer these questions, or what is the tips and tricks in this question? Fair enough, no problem. Just think over it. Think over it. No problem. Yes, Dr. Neelam. Any idea, Dr. Neelam? If the same question will come, what will you supposed to answer? Dr. Misha? Dr. Misha? Any idea? So I think,
Sorry, sir, I don't know the answers.
no, that's fine. Don't worry. I'm happy at least you are interacting. Yeah, fair enough. Fine. So today go and open up little parasite chapter. I think it's untouched, and we always think that, oh, my parasitology is excellent. You can see this one questions make you a lot of confusion in your mind. So correct answer is trichinosis. Trichinosis is a parasitic infection caused by roundworm, right? And anti-parasitic medication is the first line of treatment against trichinosis. If the Trichinella parasite is discovered early in the intestinal phase, the treatment of choice is albendazole or mebendazole can be effectively eliminating the intestinal worms and larvae. So this is the classical scenario. Same time trichinosis is caused by this roundworms. Same you need to know. I will share the PowerPoint. Salmonella is caused by the salmonella. Third thing is giardiasis is Giardia duodenalis is the name of the organism. Escherichia is caused by Escherichia lumbricoides, and shigellosis is caused by gram negative, which usually cause the diarrhea by bacteria Shigella species. Right, so that's it. So you need to read it all 4 5 things. You spend 2 hours, couple of hours about these things. It is very common across the globe, especially in developing countries. It is a very still in the people are going to moon, but still they cannot control the worms, believe me. So it's a very common problem, especially in Asian countries or developing countries, right? So this is again a little tricky questions, but not difficult. In moderate to severe asthmatic patient, you will find all of the following, except means one you cannot find: PO2 less than 60, PCO2 more than 60, HCO3 32, IV hydrocortisone will relieve symptoms after few hours, and pH is 7.45. So out of 4 things you can see in the asthma, one thing you cannot see in the asthma. What is that? That is the question. Think over it. Probably you are never touch ABG part, right? So if you did not touch, again the homework is to touch the ABG part. Open up. It's not difficult. It is easy, but we never look into it. We feel that this is the most difficult portion in the medical. Rather, it is the most easiest thing. You need to remember the couple of basic things. That's it. Only 2 answer, and we are more than 30-40 people in the class, but only answer is 2. Now 3. Now 4. Out of 40, only 4 answer. Dr. Abhishek, why this is PCO2? What you can see, doctor, in asthma? Forget about these questions. So what you see in asthma, severe asthma? If you want to try.
So in the severe, as we see in the ABG level, the normal PCO2 level is 14 plus minus 2 mmHg.
Can you read these 4 things, Dr. Abhishek? Can you see it well what I'm writing?
Yes, sir. pH, PO2, PCO2.
Let the Dr. Abhishek to answer. We'll come one by one. So what do you think? Forget about this MCQ options, everything. Leave it apart. What happens to pH in severe asthmatic patient who comes to you, right, with a respiratory rate of, say, for example, 38 respiratory rate, right? Patient respiratory rate is very high. Patient is unable to even complete one word, looks very breathlessness. All accessory muscles and sternocleidomastoid are very active, right? So this is classical case of severe, right? You diagnose on the clinical ground and you send for the ABG. You send it, right? What you will expect in this ABG? Forget about this now. Temporarily forget about this. What usually your impression of ABG in severe asthmatic patient?
Sir, patient will be acidotic, pH will decrease.
Okay, so pH will decrease. Excellent, right? So pH decrease. So first of all, pH decrease means what? 7.35 to 7.45 is the normal pH, right?
Right, sir.
Right. So you have been probably thinking that this is a less than 7.35, right?
Yes, sir.
Okay, fine. What's the next?
Next is the PCO2 level. PO2, sorry.
PO2. What do PaO2 or PO2? Arterial pressure of oxygen, right? PO2 or
Yes, sir.
PO2. So it is increase or decrease?
Sir, it will decrease.
Okay, it will decrease. What happens to PCO2? Decrease or increase?
PCO2 will increase.
PCO2 will increase. What happens to soda bicarb? Increase or decrease?
Soda bicarb decreases.
Soda carbide decreases,
Yes,
right?
sir. Yes, sir.
So on your statement only. What do you think now? Now look at the options. What do you think?
So it's B, PCO2 more than 60.
So basically, pH is usually in acidosis. What happens when there is a respiratory acidosis? When you are telling the
Sir,
term,
can I answer?
yes, you can answer.
Yes, sir. In
pH.
the respiratory
What's your name?
acidosis,
Sorry, first your name. Sorry, I lot of
my name
people.
is Dr. Ifat.
Sorry,
Ifat.
Ifat. Okay, fine. Sorry. Can you make me little mic closer so I can hear you well?
Okay, sir.
Yes, please. Go
Is
ahead.
it better now?
Little better. Go ahead.
Yes, sir. Sir, the bicarb, the bicarb increases. When the bicarb increases, there is respiratory alkalosis.
Yes.
And when the bicarb decreases, this is causing acidosis. So
Okay.
in this case, in this scenario, bicarb is increasing the normal level. So it is not possible because here in asthma we are having respiratory acidosis. So
Good.
option C is correct.
Option C is correct.
Option C, yeah, in this scenario.
So option C is correct, and that is the correct answer.
Yes, sir.
Now let's
Because
go to this.
bicarb should be
No
low.
problem. No
Sir,
problem.
sir, in
1 minute.
option B, sir, in option B, you can have hyperventilation in this case in asthma.
Yeah,
Respiratory rate is
absolutely right.
30.
Yeah. So
So,
what happens when
carbon
there is a
dioxide
hyper?
washout will occur.
So what happens when there is a lots of tachypnea patient? It's
Sir,
doing like
carbon
this, right?
dioxide washout occurs. So PCO2 will be low,
So
not high.
carbon dioxide will wash out, isn't it?
Yeah. So
Right.
PCO2 should be low.
Right. So okay, PCO2 will be low. So how do you say that this is respiratory acidosis? Respiratory and acidosis. So what CO2? What happens to CO2 when there is a respiratory acidosis? CO2 high or low? Understand first that when the
CO2 high.
CO2 high,
Respiratory.
right? So here the CO2 is less. Sorry, CO2 is high anyway, right? CO2 they already saying na high. Respiratory acidosis. So when there is a first respiratory acidosis will develop, and because of respiratory acidosis, bodies try to remove that excessive acid, right? Excessive CO2 from the body, and that is why there is a hyperventilation, and eventually there is alkalosis, right? Earlier there is a because of CO2 high in the blood, there is a respiratory acidosis, and just to wash out that excessive carbon dioxide, there is a feedback mechanism. That is why you are doing hyperventilation, and by doing hyperventilation you are removing the carbon dioxide from the body. So your usually the CO2 is high, your oxygen is obviously low, right? Hydrocortisone obviously relieve the symptoms, right? And this CO2, this HCO3, that is soda bicarb, what happens? There is a When there is a respiratory acidosis, compensatory is a metabolic alkalosis. This is what the condition will develop in the body when you have respiratory acidosis. Compensatory mechanism is respiratory acidosis, right? So here the HCO2 should be low, it should not be high. And just to understand things, let's go to the basic first. Don't get stressed. This is normal value. So they probably give in the exam, but you need to remember. I'll give you the best, easiest way to remember. 7.35 to 7.45. It's a normal. This is normal value. This is normal value, right? 7.35. If it is less than 7.35, it is acidosis. If it is more than 7.44, 45 is alkalosis. Basic things. Now remember 35, 35. Here 35, here CO2 35. Here 45, CO2 is 45. So it's easier now to remember. CO2 35 to 45 is a normal, right? So if this is a more than 45, it is acidosis, right? Higher carbon dioxide in the body brings the acidosis, lower is alkalosis, right? 75 to 100% oxygen. If it is less, it is a hypoxia, and this is a normal. 22 to 26. We need to remember 22 to 26. 22 to 26. So here carbon dioxide is more, it is acidosis, right? Here reverse. Here carbon dioxide is more acidosis. Here it is less acidosis. If the HCO3 is less, it is acidosis. If the high, it is alkalosis. It is alkalosis. And oxygen saturation, we know we do by pulse oximeter, right? It should be more than 95. Now this is normal chart. If you remember, you have lots of clarity in your mind, right? So this is a normal thing, right? Nothing abnormal. So you need to remember simple chart. Now go back to the asthma part. So in asthma, there are at least 3 category, right? What is a mild, moderate, and severe? So we are just talking about the severe as of now. So what happens severe? pH, what happens to first pH? Here mild pH increase, here normal, or pH decrease. pH decrease is like of acidosis, pH decrease, right? Because it's a respiratory acidosis. Oxygen level, obviously it is the lowest one, because when you have hypoxia and hypercapnia, so carbon dioxide is high, right? It is more than 60 as per our scenario, and this is less than oxygen saturation is less. If you can see here in the scenario, if you can see here, oxygen is less. Let me clear it little bit so you can understand well, right? So here oxygen is less, carbon dioxide is high, hypoxia and hypercapnia, this matching, all right? So this is in a severe asthma, so pH because of acidosis low, hypoxia, hypercapnia, and HCO3 should be low. It should not be high, right? It should not be high. So here, if you can see, and this is almost usually reverse. When you have CO2 high, HCO3 low. When you have CO2 low, HCO3 highs. Even remember in this simpler way as well. CO2 and HCO3 never they both gets elevated in most of the condition, right? So this is again a practical clue, right? So here your PeCO2 is high, your HCO3 is high, so it will never come in that way. So here ideally in severe asthma, your HCO3 should be low, HCO3 should be low, which is high, so that is the answer. Only here the problem is that by mistake it is pH is 7.45, so it should be by my sense it should be 7.30 in general, right? So this sentence would be correct. So PO2 is low, PCO2 is high, hydrocortisone will relieve symptoms, there is a acidosis, but HCO3 should not be elevated, it should be low, and that is why this is the answer. So you have to do, write down, homework write down. First of all, go and read ABG number 1. We'll discuss again. So read ABG basic steps. pH, PO2, PCO2, HCO3. That's it. 4 things you read it. Number 1. Number 2, what happens in acute renal failure, what happens in acute severe asthma, what happens in diarrhea patient. These 3 questions they ask usually in the exam. What I told you, diarrhea, what happens in diarrhea, what metabolic acidosis, alkalosis, how the pH. Severe diarrhea with severe dehydration patient comes to you, all right, with weakness and difficulty in breathing, what's the ABG, right? 4th question, female patients presented with oligomenorrhea, means oligolase. She has a 3 periods in last year. She also had acne and hirsutism. Her body weight was 60 kg. Per vaginal examination was normal. The diagnosis is. These are the options. Polycystic ovarian disease, hyperprolactinemia, adrenal tumor, you have a hypothyroidism, or premature ovarian failure. Either they ask diagnosis, which is what they're asking here. You also need to know how you investigate this patient. And once you do the diagnosis, how the things you will treat this patient. Take your time, 10-15 seconds. Try to. Where's Genius? Dr. Genius AP.
Hello.
Yes, sir.
Sir, answer is option A, polycystic ovarian disease.
Okay. So now you tell me, sir, what point favoring in polycystic ovarian disease? Why not it is hyperprolactinemia?
Sir,
Because in every question there is a favoring point, right? Every question has favoring point, but we never look into it. But whenever you make a diagnosis, there is absolutely in the scenario. So if you read the scenario well, you can answer any question because everything is there. Yes, tell me.
Yes,
Why
yes.
my only one question, why it is polycystic disease and why it is not hyperprolactinemia and how you differentiate?
Uh, See, it's a female presenting with oligomenorrhea.
Okay, oligomenorrhea. So you mean to say there is a oligomenorrhea favors in polycystic ovarian disease, right?
Acne, some all androgen excess features, acne, hirsutism,
Okay, so acne, I mean androgen excess syndrome is also there.
and
What else?
maybe BMI, body weight is 60 kg, maybe.
Probably weight is obese patient. Usually they are obese patient. Okay, fine.
Otherwise, examination is normal. So
So PV examination is normal. So nothing wrong in the vaginal examination. Okay, so if it is hyperprolactinemia, then how this patient present? Example. So what's your impression in hyperprolactinemia patient? Like MI patient, na? I have impression. Oh, any MI patient comes to me, he would be a 40 or 50 years age, obese, smoker, hypertensive, diabetic, family history, cholesterolemia, past history of acute MI. Patient has a severe chest pain. I will do ECG. I'll do enzyme and diagnose. This is my impression in mind before coming patient to my OPD. So what's your impression in your mind of hyperprolactinemia?
maybe galactoria will be there.
Okay, so galactoria will be there, which is not mentioned in the scenario. Okay, what else? Prolactin level should be high, which is also not mentioned. So we are not thinking. Infertility would be also there, right? They are infertile patient, right? So infertility would be also there, right? So these are the point in favor of hyperprolactinemia. Also, we need to check FSH, LH, which is not also given here. Fine. So diagnosis is polycystic ovarian disease. Fine. So this is clinical background. Now, how will you confirm it? This is a clinical background, na? You by clinical background, you understand. There is no lab here. Female presented with, sir, I have a very less periods. I only just had 3 periods in last month. I had little mustache and acne on my face. I am little obese. You did PV normal. Any test, CT scan, MRI, endocrinal workup, blah blah, sonography, pelvic sonography, anything. How you confirm? How you confirm? You need to confirm. You make a clinical diagnosis. Seeing chest pain, I make a clinical diagnosis. It could be MI, but I will confirm with ECG enzyme. So how will you confirm? Yes, Misha, Dr. Misha, Dr. Ahmadi, Dr. Bhuwana, anyone can speak up. How you diagnose polycystic ovarian disease one by one?
Sir, USG. We will do USG pelvis.
Who is this? Sorry,
Sir, Ahmadi.
Ahmadi. Sorry. Huh? Yes, Dr. Ahmadi. So what's your what will you do? Sorry, you do ultrasound.
USG, sir.
USG of which
Ultrasound.
part? Which part?
Pelvis, sir.
Pelvis. Okay, so you did a USG pelvis. What will you see in the USG now? You do, but you need to interpret, na? Chest pain, you did ECG, but you need to interpret, na? Normal, abnormal, ST elevated, normal, T inversion. So what you see in the ECG, or what's the finding? What's the finding in pelvic USG?
Enlarged ovary
Ovarian
with
cyst,
a
sir.
more than 10 cyst.
Yeah, so basically, see, polycystic ovarian disease. So there must be cyst, isn't it? That is how the
Yeah.
name comes. Na? When you do the sonography abdominal pelvis, or mainly the pelvis, what you see in the ovary is that there is a multiple cyst. That is how the name comes. Na? Polycystic ovarian disease. So because of multiple cyst in the ovary, the name comes polycystic. So first of all, you see the cyst. Then again, second question, how many cysts you see? 1 cyst, 5 cyst, 10 cyst. How many cysts you will see? Usually.
More than 10 cyst.
Excellent. So that is second question. More than 10 cysts you see in the ovaries. Third question, what happens to FSH, LH? They are normal, they are high, they are low. What happens? Each and everybody should read today polycystic ovarian disease. We are more than 50 people in class. So everybody should read, even though they know, they feel that I am the expert of polycystic ovarian disease, they can read. And if somebody feels that I am the expert, they can speak up. Yes. Speak up, anyone, open for all. Speak up, only speak up.
FSH is increased.
Sorry, doctor.
FSH is increased.
And LH? FSH increase. Okay, fine. So LH normal, increase, decrease. You should know, na? You should know. If they give you the scenario
Yes,
that
sir.
polycystic ovarian disease patient comes to you, what is the FSH LH value? FSH LH normal, FSH high, LH low, FSH LH both low, FSH normal, LH high. Then how you answer? This is MCQ. I have hundreds of MCQ in one MCQ. So go and read it later on. Don't worry. The correct answer is polycystic ovarian disease. The polycystic ovarian disease, right, is the diagnosis when there is a gradual onset of hirsutism, obesity, acne, irregular bleeding, and eventually the infertility, not having an issue. Could be a primary. There are chronic and ovulatory cycles and infertility. Chronic, not acute. There are chronic and ovulatory cycles. Periods are there, but there is no ovulation. That is called anovulatory, means absence of ovulation, right? So menses is not having menses is not an ovulatory cycle. An ovulatory cycle where ova is not released from the ovum, right? And there eventually infertility. This is what my question is. Diagnosis is mostly clinical. However, an elevated FSH slash LH slash FSH ratio is used for the confirmation. Bilaterally enlarged ovary will be found on examination and on ultrasound. Diagnosis is what? If you do the FSH LH ratio, usually it is 3:1, normally 1.5 to 1. So LH is little higher than FSH, but ratio should not be more than 1.5:1. But it is usually 3:1. Testosterone level is elevated. That is why you see the all right androgenic. The doctor told right already hirsutism, acne, blah blah. It's all testosterone because of testosterone symptoms. Pelvic ultrasound shows bilaterally enlarged ovaries with multiple subcapsular small follicle and increased stromal echogenicity, usually more than 10 cysts you find. And what's the treatment? Three things I told you: diagnosis, investigation, treatment. So here in one scenario, I had included all because in exam they may ask you the treatment. Now I'm asking you the diagnosis, but they will not go as per me. Na? I'm not deciding the DHA paper. So I'm preparing you for all. So this is the diagnosis, this is the investigation, this is the treatment. So oral contraceptive pills treat irregular bleeding and hirsutism, and progesterone component prevent the endometrial hyperplasia. Spironolactone may be used to suppress the hair follicle, right? Hirsutism. Clomiphene helps increasing the gonadotropin and it helps to improve the fertility. So infertility, you give clomiphene citrate, which improves the ovulation, and metformin is also important, which also enhance the ovulation and it reduces the insulin resistance. So this is how this treatment stepwise you have to think in mind: oral contraceptive pills, clomiphene citrate, metformin. That's it, right? Can anyone tell me what is the difference between polycystic ovarian disease and polycystic ovarian syndrome? I need one volunteer who can answer this. Dr. Arunima, are you there in the class? Probably you are in a labor room, so looks like you are in a gynec department. Okay, so if you are not available, I will go to Dr. Ramya. Dr. Ramya, do you have any idea how you differentiate polycystic ovarian disease and polycystic ovarian syndrome? It's important question. Yes, Kaushika Kalai. Do you have any comment, Dr. Kaushika, on this? Dr. Kaushika.
No, sir.
No comment. So your homework is to find out, figure it out by evening. What is the difference between polycystic ovarian disease and polycystic ovarian syndrome? Yes, Jomoli.
Okay, sir.
Jomoli Joy. Because this all learning, no? When we are reading gynec, we feel that, oh, I have done the gynec. I knows everything now. You understand? Don't take it personally. In general, I'm telling you. Dr. Ifat Makbul, do you have any idea?
Yes, sir. Polycystic ovarian disease is like only the this FSH and LH ratio is disturbed, and only the gynec symptoms come, and also the acne, hirsutism. and obesity. But for polycystic ovarian syndrome, this is a metabolic syndrome in which the patient is having hypercholesterolemia and high blood sugar also.
Excellent. Very excellent. So this is excellent, main important point. So I gathered excellent chart for you guys, right? Just to remember. That does not mean Dr. Kausika, you don't read, huh? Is that okay, doctor? Kausika,
Sir?
you have to read. Though I am giving you the idea, but you have to read, huh? Don't skip.
Okay, sir. Sure, sir.
Wonderful. Sorry for giving you homework. It will helpful.
Oh, no,
Dif
sir.
Difference between PCOD, that is polycystic ovarian disease, and syndrome. So what is the basic important thing? Occurrence. Police syndrome is less occurrent, disease is more occurrent worldwide. So if you see frequency worldwide, PCOD is more common than PCOS, number one. Number two, definition, PCOS is an endocrine disorder, and here it's a metabolic disorder. So it's the biggest difference. So metabolic disorder due to hormonal imbalance, and this is endocrine disorder of ovaries with immature follicles. So this is a syndrome is purely ovary. Presence of cyst, minimum number of cysts. So you cannot see much cyst in the PCOS. So if you do the sonography and you see only one cyst, probably it's not PCOD. Here more than 10 cysts or lots of cysts you can see in the PCOD. So this is how you can radiologically differentiate between syndrome versus disease, right? Third thing, cause. What is the cause of both the things? Here the genetic, this is also genetic, this is lifestyle, right? Syndrome, and this is insulin resistance. Insulin resistance. Severity, right? PCOS cannot be reversed. This cannot be reversed, means you cannot treat well, right? This can be reversible. Infertility can be reversible with drug, diet, exercise, and medication. Treatment is diet control, exercise, lifestyle changes, and medication is diet, exercise, medication. Even you can do the surgery and cure this patient. Complication, hard to get pregnant. It's very difficult. Hard to get pregnant. So infertility is very severe in PCOS. Risk of the diabetes, as doctor told properly, high blood pressure, obesity, endometrial cancer. Chances are increased in PCOS, which is not the case in PCOD. Easy to get pregnant with medical aid. And medical aid is, as I told you, clomiphene citrate, clomiphene citrate. So clomiphene can be given to this patient, which is very helpful and effective along with the metformin, right? So this is what the clear cut difference, simple difference, explainable, understandable, easier, right? So I will share the PowerPoint, don't worry. But you need to remember, you need to read it at home. Next question, you are called for a home, 48-year woman whose chief complaint is, I almost fainted when I got out of bed. She has been ill for 2 days with nausea, vomiting, and diarrhea. She had a temperature until this morning when it finally broke. She feels dizzy when she sits or stands up. Her skin is cool and calm. Her color is pale. Her blood pressure her heart rate or pulse rate is 130 per minute. Her blood pressure is 88/64. Her respiratory rate is 18/18. Pulse oxygen is 96% on room air. She has no medical history or no past medical cardiac history. You see the ECG here. This is the absolute ECG in front of you. What is the diagnosis? Basically, the question is, what is the diagnosis? After looking towards this ECG, what do you think that this ECG could be arterial tachycardia? It could be a ventricular tachycardia, it could be atrial fibrillation, it could be a sinus tachycardia. Any comment from any audience? Open for all. Any comment? Yes, Iram, any comment?
Yes, sir, it's sinus tachycardia.
It's sinus tachycardia. So how do you differentiate sinus tachycardia?
So there will be a full PQRS complex.
PQRS complex. Okay,
The
fine.
rhythm will be regular.
Rhythm is regular. How much the rate do you think as per the ECG? How you calculate? If I can tell you, calculate the heart rate from the ECG. This is the question now. This patient diagnosis is also sinus tachycardia. Please calculate the heart rate. This is the
300
MCQ.
divided by number of large blocks.
You do everything, whatever you want.
150.
How did you make the 150? Tell me now. How did you do 150? I want to understand the logic.
Yes, sir.
How did you brought the 150? There must be some mathematics, no? There must be some
So there is
calculation.
a formula. The formula is 300 divided by number of big block between two RR interval.
Okay, so how much is the block between RR interval?
It's kind of 2.
Wonderful. So your answer is absolutely correct. This is how we calculate the heart rate, right? So 300 divided by number of the large block between two RR waves. So roughly 2 block, right? So it's 300 divided by 2. So it's around 150, right? How you differentiate, doctor, from the atrial, this tachycardia, sinus tachycardia versus supraventricular tachycardia? If you want to differentiate between
Yes, sir.
sinus tachycardia and supraventricular tachycardia, they looks like a same. I mean, in general.
I know.
Yeah.
So in
how?
sinus tachycardia, there will be full PQRS complex, but the difference between sinus tachycardia and supraventricular, the P wave will merge with the QRS complex. So you will not find P wave.
How did you get so much of good knowledge? Teach me. Good. Wonderful. That is the reason. Absolutely right. I'm happy. Very much happy. Great. So this is a normal sinus rhythm. Without knowing normal, you never get to know the abnormal. So this is a P wave, right? So this is a P wave followed by this is Q, R, S, T. So PQRS is very clear cut. If you see, you will clear cut. Here the same clear cut. The only difference is the rate is high. So pulse RR interval is less, right? Here the normal, this is normal, right? So 1, 2, 3, and 4. So there is a 4 major blocks. So 300 divided by 4, if my maths is not wrong, it is 75. Is that correct, Iram?
Sir.
Iram. So here the same.
Yes, sir.
You can see the P, Q, R, S, T, but here hardly you see 2 block. Hardly you see 2 block, 2 block, 2 block, 2 block. So it is 300 divided by 2 means it is 150 heart rate. Bradycardia, if you can see here, 1, 2, 3, 4, 5, almost 6. So 300 divided by 6 is a 50 heart rate. Is that clear? Right? So it is a bradycardia. What is the 60 to 90 is a normal heart rate. Less than 60 is a bradycardia. More than 90 is a tachycardia. Between 60 to 90 is a normal sinus rhythm. Is that clear? Yes or no? So far clear or no? Yes or no?
Yes, sir.
Reply me at least yes or no. So here there is nothing abnormal, just the sinus tachycardia, right? Sinus tachycardia, right? So answer is a sinus tachycardia. When there is a and sinus tachycardia, dehydration, fever. These are the two most commonest reason across the globe for sinus tachycardia. Whenever you have dehydrated patient, heart is pumping fast, right? When you have fever, SA node generating the impulse is fast. So in fever, you have tachycardia, dehydration, tachycardia, right? There are a lot of reasons, but these are the two most common. So you treat the underlying cause. You don't need to treat the tachycardia. You don't need to give beta blocker in a fever patient. We never given, na? If you have malaria fever, you have typhoid, you have pneumonia. So you are not giving the 104 fever beta blocker. Why? Because it is not related to the heart. It is because of underlying condition which cause tachycardia. So you treat underlying condition, dehydration, tachycardia, pneumonia, UTI, any infection, fear, whatever. So treat underlying condition. The biggest difference, that is what I told you. See this picture. See this picture. What is above picture, Dr. Iram, and what is the below picture? I'm not given
Above
here.
one is sinus tachy or normal rhythm. Below one is SVT.
Right. So yeah. So basically, if you see right here, you can see in above, consider it as a normal. Why? Because you can see all the properly. You can see P, you can see Q, R, S, T. Here P, Q, R, S, T. Here P, Q, R, S, T. Here P, Q, R, S, T. Here again P, Q, R, S, T. Can you see here P and T wave? Can anyone see? Where is P? Where is T? Hello. Yes or no?
No, sir.
No. So the biggest difference between sinus tachycardia and supraventricular tachycardia, right? The number one difference between sinus tachycardia and supraventricular tachycardia is that in sinus tachycardia, P followed by QRST. So here first wave P and last wave T, which you cannot differentiate here. So P and T is overlapped. Biggest difference, overlapped. You cannot differentiate P and T properly. Like here you can see everything. P, Q, R, S, T. P, Q, R, S, T. P, Q, R, S, T. Got it? Here, where is the P? If I make it P, right? And then where is T then? Then there is a difficult. Whether it is P or T, no idea. Whether it is a P or T. If there is a P, then where is a T? You understand? So P and T are overlap. This is the biggest difference, number one. In sinus tachycardia, usually the heart rate is 150. Usually not more than 150 in a sinus tachycardia. If you have sinus tachycardia, usually you have between 100 to 150, but not usually more than 150. And here it starts from 150 and maximum 250. This is second difference. And third difference, sinus tachycardia patients, they are asymptomatic usually. For high pulse rate, they are very much symptomatic for their 250 pulse rate. So clinically symptomatic. Second thing is heart rate. Heart rate is very high compared with the sinus tachycardia, and P and T are overlapped. You cannot differentiate the things. And last but not the least, treatment. Here, treat the underlying cause for sinus tachycardia and supraventricular tachycardia. Right? You have a lot of things to treat for the supraventricular tachycardia, SVT. First is a carotid massage, as we know. Second thing is adenosine. If adenosine doesn't work, third is a verapamil, calcium channel blocker. If calcium channel blocker doesn't work, beta blocker, and if doesn't work, there is a cardioversion. 5 treatment stepwise for supraventricular tachycardia. Carotid massage. What carotid massage will help? Carotid, there is a vagal sinus. So if you carotid massage, right, it will stimulate the vagal nerve, and stimulating the vagal nerve, it's a parasympathetic nerve. It reduces the heart rate. So heart rate from 250 to 150, it will come down. So if the sinus carotid massage will fail, the first thing is adenosine. Adenosine also reduces the heart rate by acting on the SA node. So you give adenosine. If adenosine doesn't work, then give verapamil, that is calcium channel blocker, which also blocks the SA to AV node and reduces the heart rate. If doesn't work, use beta blocker, the same action stepwise, and nothing works, cardioversion. That's it. This is what the treatment is. Is that clear, Iram? Is that clear? Yes or no?
Yes, sir.
Wonderful. Wonderful.
Yes, sir.
So this is what the thing is. So you need to remember the basics of ECGs. Mad is a super brilliant in ECG. So those who have missed the ECG class, you can go and get the video from our website. There are few recorded videos. So you go and get it. Depressed patient has ingestion of big quantity of aspirin 6 hours ago. Came to the emergency room with a complaint of nausea, vomiting, increased respiration. Investigation so highly elevated ASA, that is aspirin. It's 200 milligram per DL. What's your action? Are you going to do the gastric lavage? You do the charcoal, you do hemodialysis, you do the alkalinization of urine. Ooh. Dr. Div Z. Sorry if I'm pronouncing your name wrong, but I can see some doctor as a DIVZ, Div-Z.
Sir.
What's your name, doctor?
Sir, I'm Divya.
Oh, sorry. I mean Div-Z. Yes, Divya. So what's your explanation, answer, your comment?
So actually, for poisoning with aspirin, better to have alkalization of the urine, but in this case, the salicylate is also elevated. So I think it's better to have hemodialysis.
So where you supposed to answer the alkalization of urine, not
Uh,
hemodialysis?
like it's mentioned like highly elevated level of ASA. So I thought like to do hemodialysis.
No, no,
Otherwise, I would sign.
your answer is correct. I'm not refusing. I'm just trying to understand from you.
Yeah.
So, is there any level in the blood where you do the alkalinization or any level in the blood where you do hemodialysis? It's on the
Uh,
amount, it's
Sir,
on the time frame.
hemodialysis more than 100.
Okay, great. So this is some cutoff line. Sir told the number, right? So more than 100, you maybe have hemodialysis. So hemodialysis is the correct, but not due to 6 hours, but due to the serum aspirin is very high. Hemodialysis can be used to enhance the removal of salicylate from the blood, usually in those who are severely poisoned, like this patient. Example of severely poisoned, including people with a high salicylate level, more than 100, as Sir rightly said, it's 100, and in our scenario, it's 200, right? So in our case, it is a 200. It's double than dangerous level. So you must do something urgently, which removes the salicylate from the plasma, and that is a hemodialysis. That's it. Next questions. You read it later on. ASA poisoning. It is very common questions. There are hundreds of questions, but I want to cover more questions. So you go and read three poisoning. Write down in your note three poisoning you must know. They will ask. One, paracetamol poisoning. If you have acetaminophen poisoning, how you diagnose, how you investigate, how you treat. All three tried. Second, aspirin or salicylate, how you diagnose, how you treat, how you investigate. Third, poisoning, how you alcohol, ethanol overdose or methanol overdose, how you diagnose, treat, and treat. That's it. So three poisoning is very common. You must know. All are associated with men. What do you mean by men? Not male, female. MEN is multiple endocrine neoplasia type 2, right? So all are associated with men too. Only one is not associated. Which is that? Pheochromocytoma, isolate Langer, isolate hyperplasia, medullary carcinoma of thyroid, parathyroid adenoma. Yes, Dr. Nosh. Would you like to comment, Dr. Nosh? Quick, just to save time, yes or no? Fine. So this is not a very long scenario. So answer is a, see, this is the simple and excellent pictures I shown everyone. Man 1, man 2, man 2B. Man 1 is what? Pituitary adenoma, parathyroid hyperplasia, and 3 is a pancreatic tumor. This is man 1. Right? So here you remember 2P. Then there is a first 3P. P for pituitary, P for parathyroid, P for pancreas. So 3P. Then in second column, 1P is reduced. And third column, more 1P is reduced. So 3P, 2P, 1P. Simpler way you remember. Here M0, here M1, here M2. So it's easier way, right? 3P M0, 2P M1, and there is a 1P M2. That's it. So overall is 3, right? So Man 2A. So parathyroid would be the common in both. Another new thing added is a medullary thyroid carcinoma, right? Parathyroid plus thyroid. And instead of pancreatic tumor in man 1, here pheochromocytoma. So pancreatic tumor from pancreas, pheochromocytoma from suprarenal gland or adrenal gland. What is the fine adjustment between man 2 and 2B? So here what is the common is medullary thyroid carcinoma is same in both. Pheochromocytoma is both. So thyroid and pheochromocytoma is same. What different? Right? 2M, mucosal neuroma and marfanoid, right? So here, as I told you, 3P, 2P, and 1P, right? So here, what is not there in the man 2? Man 2 is isolate is not there, pancreatic tumor or isolate is not there. The rest of all things are there in man 2. Pheochromo is there, medullary carcinoma of thyroid, parathyroid adenoma is also there. You can see all this: thyroid, parathyroid, pheochromo, all there. Not there is a isolate cell hypoplasia. So if you have not touched the man 1 or 2, go and read it. Extremely important, very high yield question. Don't neglect. Probably I know you don't know man 1, 2, 3, confused. but don't get confused. Read it once again. 89-year-old woman is diagnosed with metastatic breast cancer to the lungs, bones, brain. 4 months after diagnosis, the patient is admitted to the hospital with excruciating bone pain, changes in her mental status. What terms refer to the administration of morphine to relieve this pain with incidental consequences of causing respiratory depression and death? Simpler way, metastatic breast cancer, you are trying to kill the patient by giving the high dose of morphine. You want to make it him out of suffering. What is called as indirect euthanasia, involuntary active euthanasia, non-voluntary active euthanasia, passive euthanasia, voluntary active euthanasia. If you did not read the legal ethics, go and read it. Here there is no logic, you need to mug up anyway. So answer is administration of morphine or other medication to the relieve pain with the incidental consequences of causing respiratory depression leading to death is known as indirect euthanasia, and it is illegal everywhere in the United States, not in India, right? So we are not supposed to give high dose of morphine and let the patients to go away from suffering, right? Still it is not legal, but in USA it is illegal. It is the indirect euthanasia, right, where you give the high dose and relieve the pain. Next question, a patient comes with epigastric pain with that is associated with substernal chest pain and unpleasant metallic taste in the mouth. What is the next best step in the management? So they are asking the management. Is it endoscopy, barium study, proton pump inhibitor, H2 blocker, or a 24 hours pH monitor? Answer fast. Simple question. Yes, anyone wants to try quick diagnosis, investigation, and treatment? Anyone quickly? Anyone? No one wants to speak anything?
Yes, sir. PPI, proton pump inhibitor, is the first line.
What
This
is
is
the
peptic
diagnosis?
ulcer disease, maybe.
This is peptic ulcer
Peptic ulcer
disease.
disease.
So how did you get to know this is peptic ulcer disease? What point favors in peptic ulcer disease? Yeah,
Sir,
tell
the
me.
epigastric pain and the metallic taste of the mouth.
Okay, so metallic taste, isn't it a GERD, right? Because something comes from
GERD.
the, yeah, so something comes from the stomach to up to the esophagus and coming up to the throat. So looks like a GERD, isn't it? So the patient comes with the epigastric pain with associated with the substernal pain and unpleasant metallic taste. So unpleasant metallic taste, mug up until proved otherwise is GERD, right? Because acid when comes back to the from stomach to mouth looks like a metallic taste, and this is GERD. When you have this, your answer is correct. I'm just trying to make you understand. Proton pump inhibitor are preferred first line therapy for severe therapy and also serve as a diagnostic test. Using PPI is far easier, better, economical than doing testing, blah blah blah. In addition to epigastric pain and substernal pain of GERD, several other symptoms are clearly associated with acid reflux, that is metallic taste, hoarseness, chronic cough, wheezing. 25% of the chronic cough is caused by GERD. So every time when there is a chronic cough, don't look at the lung, cough lung, look at the GERD, because 25% means 1 out of 4 patient has a GERD, and because of GERD, chronic irritation, chronic reflux disease, they have irritation in the throat and larynx, and they present with the cough. So you are doing hundreds of X-rays, CT scan of chest, but you are not giving PPI. So just give PPI. It's the easiest way. That's it. So this is a GERD. Give the PPI. Next, 56 years old man present to his urologist for continued evaluation of hypertension, hematuria. Patient has a 10 years history of hypertension and recent onset of painless hematuria, for which he sought the attention of the urologist 3 months ago. On detailed questioning, the man states that he is having a severe headache. There are refractory to the narcotic analgesic. 3 days ago, renal ultrasound was obtained that demonstrated bilateral enlarged kidney with multiple cysts. Which of the following is most appropriate next step in the diagnosis. CT scan of thorax pelvis, CT scan of thorax pelvis, intravenous pyelograph, MR angiogram of brain, none of the above. First of all, understand what is the diagnosis of this patient. Yes, anyone can tell me what is the diagnosis of this patient primarily?
Polycystic ovarian disease. MR angiogram
So where,
brain.
Sir, polycystic kidneys. Polycystic kidneys.
yeah, so sir, polycystic kidney disease or ovarian disease?
Polycystic kidney disease.
Yeah, so you told me ovary, but it is not ovary. This is polycystic kidney disease, isn't it? Because there are a lot of cases.
Brain.
Right. So what you want to do?
Aneurysm should be ruled out.
Wonderful. So aneurysm should be ruled out in the brain. So what is the condition? What is the correlation between kidney and brain? Why you want to do MRI brain angiogram? What condition you are thinking in the brain? Those patient who has a polycystic kidney disease. What you so like aneurysm in the kidney, there may be aneurysm in the brain, right? So the most important when which of the following is the most appropriate next step in the diagnosis. So you need to do. There is a high chance inherited that he may develop the brain and he may die. So hypertension, right? Complication is what of polycystic kidney disease. Hypertension 60 to 100% patient. Cardiovascular complication are major cause of mortality in patient with acquired polycystic kidney disease. Infection is the most second cause of death in patient with polycystic kidney disease. Gross hematuria, nephrolithiasis, renal failure in 50%, right, by age of 60, polycystic liver disease, and cerebral aneurysm occur in up to 10% of the patients. So very interesting story. So case of adult onset of polycystic kidney disease, intracranial saccular aneurysm, also known as a berry aneurysm, has a well-known association with autosomal dominant polycystic kidney disease. Excellent, important, isn't it? Oh my God. Is that clear, doctor? So polycystic ovarian, kidney disease, whenever you comes across, always go for the MRI brain and try to figure it out. There is no aneurysm because there are high chance of mortality, aneurysm ruptures. Prevalence of intracranial aneurysm, risk of rupture and consequences. The prevalence of intracranial aneurysm estimated in between 12% of the patient with this polycystic kidney disease, and in comparison intracranial aneurysm prevalence in the general population is 2 to 3%. So general population 3%, but in with the polycystic kidney disease it's almost like double or 10 times, sorry, instead of 2 it's 12% or 5 to 10% high. So that's it, this is the answer. Important questions, surgical questions, little tricky questions. 16-year-old girl is brought. Don't afraid of having long scenario. 16-year-old girl is brought to the emergency department by ambulance after she has extracted from the burning vehicle that had been in an accident on the local highway. She was the only person in her car, which burst into a flame after being rear-ended at high speed. She is swayed off the road and collided with the side railing when the ambulance arrived. She was unconscious in the driver's seat. On arrival at emergency center, patient is a moderate respiratory distress, high pulse rate around 120, blood pressure is low, 80 over 40, respiratory rate are 30, which is also high. After securing the airway and administering the oxygen and intravenous fluid, the physician evaluated the extent of the sustained burn injury. There is a diffuse erythema and edema on her face. Most of her scalp hair is crushed with some blistering of underlying skin. Both arms below shows diffuse erythema, edema, and areas of extensive blistering. The rest of her body shows no significant burns. Which of the following is estimated body surface areas of the burns? So basically, there is a long story short. Young girl has accident, blast in the car. She was alone. Vital is unstable. She had burns area on blah blah this area, which you need to calculate and tell what is the percentage of the burns. Here you apply rule of 9. If you apply rule of 9, you can easily see. So if you don't have time in such long scenario, tips from my side, in exam, read last 3 lines where you probably get the answer. Yes, Dr. Anitha, can you give me the calculation, Dr. Anitha?
Her face is 9%, both arms 9% each.
Okay. So how much is the final answer?
27.
Great. This is a Parkland formula. This is second question in exam. So once you calculate the things, you need to calculate the fluid as well, right? So Parkland formula applies only for second and third degree. It does not apply to the first degree or superficial. So what is the formula? This is second. If they ask, this is the question they ask, how much is the percentage? So answer is correct. But now they, how much fluid you replace? What's the treatment? Right? Of 27% bulk. So this is the answer. 4 ml into body surface area, right, in terms of multiply by body weight in kg. So whatever that comes, say for example 5 liter fluid comes, right, first 2.5 liter give in 8 hours, second 2.5 give in 8 hours, 16 hours, sorry. So total fluid should be divided in 24 hours, half in first 8 hours, half in next 16 hours. That's it. So here the rule of 9, everything is 9 except genitalia in adult, right, it 1%. Otherwise head, chest front and back, abdomen front and back, right upper limb, left over limb, and right leg and left leg, front and back 9. So total, if you 11 by 9, 99%, and genitalia 1, so total 100%. That's it. So most important step here is to give the oxygen. Already they have started, because in a fire burns, yeah, there is a carbon monoxide poisoning. So they started oxygen, they started the IV fluid. They are asking how much is the percentage of burns. So 7% face and both arms. 9 plus 9, 27. Next, patient lost his wife by acute. So those who don't know how to calculate, go and read again the Parkland formula, or read and open up the burns chapter. Extremely high yield question in exam. Partner lost his wife by acute myocardial infarction and cardiac arrest 6 months ago. He presented with loss of appetite, low mood, sense of guilt. What is the diagnosis? Bereavement, major depression, anxiety disorder, bipolar disorder. You can, Doctor, unmute Anitha by your, you can do unmute by your own. There is a mic below. You can mute and unmute by your own. Yes. Yes, Dr. Ahmadi, what's the diagnosis? Dr. Ahmadi,
Yes, sir.
what is the diagnosis?
It is likely to be depression, sir. Major depression episode.
Okay. So now tell me 5 or 6 point which favors depression. If you want to tell any patient that he is a depression, or if you want to make a depression, there is a diagnostic criteria of depression, 1 to 6 criteria. Do you know, yes or no? Yes or no?
No, sir.
So your, okay, no, don't worry, it's fine. So your homework today is to read the, open up the book, psychiatry chapter, and read the depression. 3 things you read: depression you read, obsessive compulsive disorder you read, right, and bipolar disorder you read. 1 question or 2 question will come from these 3. So you need to know. Okay, doctor? Is that okay
Yes, sir.
with the homework, or not comfortable?
Yes, sir. No, I will do it.
Wonderful. 3 topics, and tell me once you're done. I will again discuss with you 1 to 1. I don't
Okay,
want
sir.
anyone to lose any single marks. Yes, Dr. Kutti, any comment? Dr. Kutti, Shahid Moiddin Kutti, any comment? No comment. So this is what the basic difference between the, you need to know all this, what is the bereavement, what is depression, how you differentiate. It's important. It is excellent MCQ given on our website. If you go through it, probably 50, 100 MCQ, you get a lot of clarity. So this is bereavement and this is major depression. May not be associated with death, always associated with death. So there is a first line, what they're saying is lost, right, or died. Partner lost his wife by acute MI. So death, basically death, cardiac arrest, right? So this is the number one most important in bereavement is death, related with death of close relative, either father, mother, sister, brother, like that is history. Duration is 12 months, here short duration. Here they had given 6 months, so it's a long period, it's bereavement. Preoccupied with cause of circumstances of death. So there is something related with death. Here feeling of worthlessness. Here the treatment is therapy, psychotherapy, or cognitive behavior therapy for bereavement, and here SSRI, selective serotonin reuptake inhibitor, and ECT, electroconvulsive therapy. Right. So you go and read it in detail. I will share this PowerPoint. Right. So you need to know the time frame. You need to know the symptoms. You need to know the everything for depression. Depression is global problem. It's a non-communicable global problem. 4 years old child with brought by his mother because of red spot and rashes on her lower extremity. Today she fell from today she fell from her bicycle and was bleeding for 30 minutes. She has no known medical problem. The only significant history is a recent upper respiratory viral illness. Examination revealed patechi and lower limb and purpura on her buttock. There are no signs of active bleeding. PT and APTT and bleeding times are within normal limit or normal. Platelet count is 32,000. Hemoglobin is of 12. What is the next step in the workup? Means investigation. Bone marrow biopsy, factor level, mixing study, peripheral smear, ristocin assay test. Diagnosis or differential diagnosis. Diagnosis or differential diagnosis. Yes, Monica Gupta, why you want to do factor level? Tell me. What is the diagnosis, Monica Gupta?
Hello, yes, sir. Factor levels, I think so factor levels is not required, factor level is required to rule out hemophilia.
Fine. So do you think it, first of all, in any bleeding patient, right? This patient has a bleeding, right? See,
Yes.
simple. Listen the logic. Spot
Yes.
and rashes from her lower extremities and bleeding for 30 minutes, blah, blah. So
Yes.
first of all, decide whether it is a platelet bleeding or factor bleeding. Most commonest questions or thought process in the clinic while we are, if I'm in the clinic, in the emergency room and some patient comes with a bleeding, what I'll should, whether it is a platelet bleeding or whether it's a factor bleeding. So you
Yes.
decide now what happens to platelet. Platelets are
Platelet
normal or
count is
abnormal?
decreased. Platelet count is decreased.
So platelet count is decreased. So
It
what it
might be
could be?
ITP.
Excellent. So
ITP.
it could be ITP. So when there is a
Yes.
you are suspect in some case as a ITP. So what test you will first do from A, B, C, D, E? Bone marrow you do for ITP, factor level you do for ITP, mixing study you do for ITP, peripheral smear you do for ITP, or ristocin assay you do for ITP. What will you do?
ITP,
You are absolutely right. You're going well. You understanding the logic well. So when you think that there should be ITP, what will you do first? What's in your mind and why? What and why?
Sir, it is an ITP case. Active bleeding PT and APTT is normal. within normal
Yeah.
limits.
Yeah,
Bleeding
that
time is within normal limits.
so that's all well, doctor. Now what you want to do? So in case of ITP, if you suspect some patient as ITP on clinical ground, you do CBC, and after CBC, what will you do the next? CBC you are done, na? Hemoglobin 12, WBC is normal, and platelet is 32,000. PT,
Yes.
APTT is normal, bleeding time is normal. So what next you want to do? Yes, Dr. Iram. Yes,
Sir,
Iram.
I would like to do peripheral smear.
Okay, why you want to do the peripheral smear?
I
What will you
want
see in the peripheral smear in ITP?
decrease number of platelets.
Wonderful. First thing, what else you see in the peripheral smear? Platelet size is normal, small,
No, sir.
or large?
I have no idea.
Important question. So you can see the large size platelet, right? So why you want to do the peripheral smear? Because peripheral smear you want to confirm one thing, right? There is a no pseudo thrombocytopenia, right? By seeing the platelet under microscope, that okay, platelets are low. Also, you can get the idea about some other pathology like viral infection, leukemia, right? Or some other disorder can be diagnosed on peripheral smear. So first, any hemato, fix in your head. I'm practicing hematology for 20 years. So don't jump directly on the hi-fi investigation. Basic is basic. You cannot jump, right? You have chest pain and you directly do angiography. Don't do angiography. First do ECG, second do enzyme, and then angiography. No center in this world doing ECG and enzyme. Without ECG and enzyme, no hospital in this world doing angiography directly. Chest pain angiography, nobody will do in the world, in US as well. Chest pain, ECG, enzyme, diagnostic confirmation, PCI. Is that clear? Yes or no?
Yes, sir.
So any hematological condition, CBC, peripheral smear, and then bone marrow. You cannot directly jump on the bone marrow without CBC and peripheral smear. So peripheral smear will confirm the diagnosis that platelets are low. Is there any other associated abnormalities? You can see, right? So peripheral smear is always number one in any hematological condition. Bone marrow is done just to confirm the diagnosis, but it is after peripheral smear. Factor level is done when you suspect when there is a clotting problem, and which is reflected by high PT and APTT, which is normal here, right? PT and APTT are within normal limit. They are mentioned, right? So no need to do factor level. Mixing study is done only when PT or APTT is high, which is normal. Ristocin assay test is done for von Willebrand factor activity, which is not the case here, because in von Willebrand factor, what is the problem? PT, APTT is high, bleeding time is high, which is not there. So we are not suspecting, and usually platelets are normal, right? Except advanced condition where platelets are low. So if it is a von Willebrand factor, there should be APTT should be high, which is normal here. Bleeding time should be high, which is normal here, right? So this is all point against the von Willebrand factor. Mixing study again the low platelet because it is done in high PT APTT. Factor level when we are suspecting there is a factor deficiency, and bone marrow biopsy is the final investigation once you do the clinical and initial investigation, right? And bone marrow will not give much clue in ITP because it's a diagnosis of exclusion. So bone marrow is probably normal, except increase the number of megakaryocytes in the bone marrow. That's it. That is what I can see in bone marrow. My bone marrow biopsy video is available on YouTube. So somebody wants to see, they can see. Bone marrow biopsy by Dr. Munjal. You get a lot of videos of bone marrow. Anyway, so that's it. So this is ITP, right? Classical ITP, usually seen in children, usually seen, right, with the upper respiratory tract infection followed by upper respiratory tract infection. There is a thrombocytopenia, and with thrombocytopenia, they have little bleeding, ecchymosis, petechiae, blah blah. So now you do the things, diagnose the things, and treat the patient. That's it. This is the treatment part, very important. Many a times they ask in the exam. Just I'll take 5-10 more minutes. That's it. All we are done. If there is a no bleeding with low platelet, when there is a more than 30,000 platelet and no bleeding, don't treat, no treatment. Mild bleeding and less than 30,000 platelet, glucocorticoid or steroid. So steroid is the treatment of choice. IVIG and NTD. So there is a one more question, high yield question. Every time they ask in exam, when the IVIG and NTD use. IVIG means IV intravenous immunoglobulin and NTD. But this is what the same what we do in a RH incompatibility or this ABO incompatibility, RH incompatibility in mother and baby, right? So same NTD. So these are given in only two conditions. I remember as a BB, bleeding in brain means intracranial, and bleeding in bowel, massive GI bleeding. These are the only two conditions in emergency. So any patient with ITP present with brain bleeding or bowel bleeding, you give anti-D or IVIG. That's it. These are the two only indication. You don't need to do from gum bleeding. So when there's simple small gum bleeding, don't give 5 lakhs rupees of IVIG. It's not helpful, right? So mild moderate bleeding not required. Severe bleeding, life threatening bleeding, bowel and bladder and brain, you can use this. That's it. And if they ask what is the first line treatment of ITP, then it is a steroid. ITP is a diagnosis of exclusion. ITP only low platelet with CBC and large platelet and megakaryocyte in blood and bone marrow. And ITP is a treatment of choice. First line treatment is steroid or prednisolone. 70% will remain achieve remission. 37-year-old woman present to a physician with 3 days of fever, fatigue, and rash. Her medication includes oral contraceptive. Her temperature is 38.7 or 101.7. She has also a non-palpable petechial rash and splenomegaly. Coagulation study and fibrinogen levels are normal, but a complete blood cell count show hemoglobin of 9.7, platelet of 135,000. Peripheral blood smear shows cystocytes. Which of the following is most likely diagnosis? Disseminated intravascular coagulation, HELP syndrome, Henox-Collin purpura or HSP, idiopathic thrombocytopenic purpura, thrombotic thrombocytopenic purpura. It requires lots of hematological correlation and clarity in your practice. It's little tricky questions, not difficult, but you need little experience in hematology just to rule out one from another. Yes, last couple of questions, so just bear with me 5 more minutes. Yes, please. Yes. Anyone in the chat box? No one in the chat box. Answer. Yes, Iram. I usually ask those who put the answer. Yes, Dr. Iram.
Yes, sir.
What's the answer? What's
ITP.
Okay. ITP. So first of all, let me tell you, this is not the ITP case, but still we'll discuss as an educational purpose. Is that clear?
Yes, sir.
Okay. So now you tell me why you selected ITP. What point favors in ITP, first of all?
Purpura.
Purpura. Okay, I write down whatever you are saying, purpura. Okay, what else? Purpura is the main diagnostic point of ITP or low platelet is main point of diagnosis?
Thrombocytopenia is the diagnostic.
Okay, fine. So I write down thrombocytopenia, but answer is not ITP. I'm just trying to make you understand the things. Okay, fine. Third thing, which favors the ITP? Now I'll tell you. Do you think there is a fever in ITP usually? Yes or no?
No.
Usually no. So this is against. Second thing, do you think there is a splenomegaly in ITP? Yes or no?
No, sir.
Usually no. Because ITP's diagnosis of exclusion, there is never hepatomegaly or splenomegaly, very rarely. Do you think there is a low hemoglobin in ITP? Yes or no?
No.
No. Do you think there is a cystocytes is in ITP? Yes or no? What do you mean by cystocyte? This is normal RBC. And when the RBC gets broken, it's cystocyte. It's like it's a broken RBC, half RBC, broken RBC, small RBC. Broken RBC is a cystocyte. So if you have a chronic this Because of drug, there is a cystocyte. Because of infection, there is a cystocyte. Because of prosthetic valve, there is a cystocyte. Because of DIC, there is a cystocyte. Cystocyte is basically a broken RBC. Simple. Okay. So now your diagnosis would be same, or you want to change it? So do you think
It will be different. The answer.
So what is the second most answer? If I give you the liberty and opportunity, right, to change the answer, what will you change second?
Sir, I can say like DIC option A. There is no
One minute.
coagulation.
Don't take it as DIC. So DIC is also not the answer. It's a wrong answer.
Yeah.
Now tell
In the
me
help,
why you tell the DIC? What point favors in DIC? So DIC means what? DIC
there will
means
be deranged coagulation profile, PTA, PTT.
okay. So do you see the deranged PT, APTT in this scenario?
No, sir. And the
So
platelet count would be low.
yeah, so platelet is low. That's fine. Mild low, but it's low anyway. But PT and APTT should be high, which is not there. And let me tell you, if something is not mentioned, means normal. Just for your knowledge, something ECG is not mentioned here means normal. BP diabetes not mentioned means both are not there, absent. Got it? So DIC, do you think it is a DIC?
So we can exclude DIC, what I want to say. Then we can exclude help.
Okay, so DIC is not there, right? Because DIC, what happened? Let me tell you.
Yes, sir.
Platelet count is low, and because of factor, this consumption, PT and APTT would be high. So which is not there. So DIC is excluded. HELP syndrome.
There will be elevated liver enzyme, which is also not there.
Okay, so
And hemolysis.
full form of this is hemolysis, elevated liver and low platelets. So low platelets are there, but elevated liver enzymes are not there. Means liver function test LFT is not abnormal here. So HELP is not there. And biggest thing is the pregnancy, isn't it? Pregnancy, many a times. Anyway, HSP is there or not? What is HSP? What do you mean by HSP?
What, sir?
What is HSP? Hinox colon purpura.
So, sir, this is also like hematological issue in which there will be a history of respiratory or GIT infection.
No, not at all. Hinox colon purpura is not hematological problem. It's an autoimmune problem. It's a vasculitis problem. So your homework is to read DIC. Your homework is to read HSP. These all our questions will come in exam. So now what else? You are saying DIC is not there. HELP is not there. HSP is not there. ITP is not there. Then what's remaining is a TTP. This is the case of TTP. TTP is a thrombotic, thrombocytopenic purpura. There are classical pentad. Pentad means 5. Triad means 3 things. Pentad means 5 things. Pentad. So what is the pentad of TTP is? There is the anemia, low HB. Yes, it is there. 9.7 is a low HB, obviously. Right? Low platelet count, thrombocytopenia. Yes, low platelet count. Third thing is usually many a times, right? There is a fever. Yes, it is a fever. Fever is there. Where is the fever? 101 fever, right? Third thing is a neurological deficit or neurological involvement, which is absolutely differentiate from TTP to HUS. There are 2 conditions. So you go and read the HUS as well, hemolytic uremic syndrome. And sixth thing is a serum creatinine or renal insufficiency. This is pentad. 5 things are there: low HB, low platelet, fever, neurological, and high creatinine. And because of the hemolysis, there is a cystocytes. So this is a thrombotic thrombocytopenic purpura, right? So this is a classical case of TTP. Thrombotic thrombocytopenic purpura is a disorder of the increased platelet aggregation leading to mucocutaneous bleeding, patechi or purpura, and hemolysis, both hemolysis plus thrombosis. Even though there is a low platelet, there is a thrombosis. Very interesting. Most cases are idiopathic, but the condition associated with a certain medication, cyclosporin, clopidogrel as well, and oral contraceptive. Classical pentad thrombocytopenia, microangiopathic hemolytic anemia means low HB, low platelet, mental status, neurological fever, and renal failure. Although the last three may not be present, diagnosis is confirmed with the unexplained thrombocytopenia and microangiopathic hemolytic or hemolysis and cystocytes in the peripheral blood. The most important thing, Dr. Iram, is in HSP, Henox choline purpura, the platelets are normal. Dr. Iram, platelets are normal.
Yes, sir.
So it's a vasculitis. It's not a hematological problem. Go and read the HSP, right? And what is the treatment of HSP? You also read that because this is very commonly question comes. So whenever there is a HSP, only there is a patechi purpura or because of vasculitis, but platelets are absolutely normal, not low, which is low here. So this is the differentiating point. HSP is a vasculitis in a children, immune complex, platelets are normal. And ITP, you know it, ITP, right? Last but not the least, mifepristone is an effective abortifacient if given within 72 hours of intercourse. Mifepristone contains which of the following? Estrogen, progesterone, high dose of estrogen, progesterone antagonist, progesterone only, and prostaglandin. Mifepristone is an effective abortion inducing, simpler way, if you give within 72 hours of intercourse. So if somebody has an intercourse or rape or some things, right, they don't want to this keep the pregnancy. So if you give mifepristone in 72 hours, it is an abortifacient, or it induce the abortion, or it will not keep the pregnancy. So what is this mifepristone? ABCD. Okay, so there are various answers. The correct answer is this. Let me go to this. Mifepristone. So answer is C. Mifepristone is antiprogestin that has been shown 100% effective at preventing the pregnancy if it is given within 72 hours of intercourse at one time dose of 600 milligram. Right, so it is antiprogestin. Answer is progestin. Antiprogestin means antagonist. Anta means antagonist of progesterone. That's all. So I'm done from my side. Thank you very much all for listening me for at least 2 hours unbeaten uninterrupted class. Thank you very much. Last but not the least, I want few quick feedback, especially for those who joined first time and what they have learned new, something new today lecture. Anyone, quick, just last 2 minutes. Open for all, anyone. I would be happy to have your feedback in terms of quality of questions, content, explanations, timing, blah, blah, everything. Yes,
Very
doctor.
beneficial lesson, sir. Thank you.
Can you please speak your name so I can at least?
It's me. I am Bahar Toprak.
Yeah. Oh, sorry. Great. So you are an old user, so you probably knows better. I'm just trying to understand. Dr. Ifat Makbul, any comment from you? Dr. Misha.
Yes, sir, it was very informative. Thank you so much. So many
Wonderful.
points are clear, just like the angina, unstable angina. I am always confused. I read many times, but the way you explained, it is the best. Thank you.
Wonderful. Wonderful. So I don't want you to miss the cardiology now, right? Okay, great. Any other second, any candidate? Dr. Ahmadi, any comment? Dr.
Sir,
Arunima? Yeah.
me, Dr. Monica, sir. Thank you, sir. Your class is always a great class, sir. I really appreciate you, sir. And you very well explained the supraventricular tachycardia, sinus tachycardia, the unstable angina was very well explained.
Wonderful. I'm happy at least you learn the
you,
things.
sir.
Yes, Iram,
Thank you
how
so
was your
much.
experience? This is your first class, Iram?
Yes, sir, it was my first class. I
Anything
got to know
anything you knew you
a
learned?
lot of about my weak points where I need to work.
Sorry?
Hello.
Yeah, so you get to know something
Hello.
new. You get to know something new from
Yes, sir.
in ways, right? The way you are doing alone and with the expert you are doing. Do you find some?
Yes, sir. There's a huge difference.
There is a huge difference. Great. So I want you to utilize the tips and tricks what I had given you. And last but not the least, Dr. Pooja, would you like to comment anything on this lecture?
Hello, sir. This is Dr. Abhishek this side.
Yes, Abhishek sir, you are with Dr. Pooja?
Yes, yes. So
Okay,
she
fine.
is
So
called
just
for
send me,
consultation.
no problem. Just send me your
Yeah,
number so I can be in touch with you. I have
sure,
madam's
sir.
number only. So anyway, so
Sure,
how
sir.
was the learning today? How did you find this class?
So the class is superb. I got my lot of my queries cleared with the help of the great explanation by you on the ECG.
Wonderful. Wonderful. So we have a excellent class of ECGs, dedicated 1 or 2 class of ECG by Madis. She is also expert. So you
Sir.
can attend later on if you are willing to join a
Sure,
coaching.
sir.
Anyway,
Sure, sir.
fair enough. And lastly, Dr. Misha, any comment? Then we'll pack up. Dr. Misha or Dr. Ifat Makbul, last comment. Anything new you learned? Dr. Arunima or anyone last? Something new, I mean, you learned which you never thought of, or something new creative you find that, oh, this is very interesting. Anyone last? Okay, great. No problems. So thank you very much all your for kind attention. So we'll keep in touch. I will share this complete lecture by end of the evening to you guys. So keep in touch, stay tuned. And if you need any help, feel free to contact us. Thank you very much and enjoy your Sunday. Thank you.
Thank you, sir.
Thank you.